Welcome to the second in a three-part webinar series on neonatal abstinence syndrome, or NAS. I'm Julia Tipton Hogan, the Executive Director of the Indiana Perinatal Network. This webinar series is brought to you by MDWise, an IPN Silver sponsor to whom we are so grateful. We also want to thank our 2017 education partners, Anthem, Clark Memorial Hospital, Franciscan Health Indianapolis, Franciscan Health Lafayette East, Parkview Health, Reed Hospital and Healthcare Services, and St. Mary's Hospital for Women and Children. Today's webinar is called NAS from the Pediatric Perspective. Our presenter is Dr. Emily Scott, a pediatric hospitalist and medical director of IU Health Methodist Newborn Services. We will have time for questions at the end of this hour, and Dr. Scott is live, so she will be answering her questions, the questions you send live. Today's continuing education is being provided by Indiana University Health. You will receive an email from IU Health with the evaluation form, and you must return the evaluation. The directions will be included to get your CE credit. And now here's Dr. Scott.
Hi, everybody. I'm very excited to talk to you guys today about neonatal abstinence syndrome. It is something that we are seeing a lot more of in our one hospital here at Methodist and all throughout the state as well. I have no disclosures to give you guys. I will say that all the pictures in the slides are of my own children, not of babies suffering from NAS. Our objectives that we're going to review today are to make sure everyone is recognizing the growing rates of NAS in our community, discuss evidence-based practices for screening, monitoring, and treating neonatal abstinence syndrome, and then I think most importantly, reviewing some tips to create a positive, supportive environment for our families and medical staff when we're dealing with this patient population, which can be difficult at times to manage. I will say that I am not an expert by any stretch of the imagination, but I do deal with this on a day-to-day basis, and so I've gotten a lot of practical experience in dealing with these moms and babies as well. So I wanted to start off by sharing a story with you guys. A few months ago, I was rounding on newborns like I do every day at Methodist. It was a really busy day, and I had seen all the babies going home that day very early in the morning so that we could expedite their discharge. Around 11 a.m., I received a call from one of our great nurses. She told me that she was getting ready to draw the 48-hour newborn screen on one of the babies that I'd already discharged that morning after seeing it about 6 or 6:30 a.m. But she had noticed that the baby was breathing really fast and wanted me to come back and take another look. I reviewed my information on the patient. She was a full-term newborn, born to a first-time mom. Mom had moved during her pregnancy and had inconsistent prenatal care. Mom and baby both had negative urine drug screens. The baby's father was no longer involved. The maternal grandmother, however, was in the room all the time and was a great support to Mom. Mom had been breastfeeding exclusively and was incredibly involved in her newborn's care. In fact, I'd spent a significant amount of time the day prior discussing breastfeeding and newborn education with them at home. Our conversation had drifted into the baby's nursery decorations, our mutual love of dark chocolate-covered pretzels, and reality television shows we liked. Mom and Grandma were awesome, and I'd really enjoyed my time spent with them the prior 2 days. When I'd seen that baby around 6:30 in the morning, Mom had described what sounded like cluster feeding behavior all night. The baby herself was fussy during my exam, but otherwise looked very well and was not tachypnic at that point in time. When I handed her back to Mom, she consoled really quickly on Mom's chest skin to skin and started to breastfeed. So I really didn't have a lot of concerns that she was more fussy than she should be. However, when I went back to look at her around 11 a.m. after getting the call from the nurse, the baby was clearly breathing fast. I took her to our treatment room to put her on the monitor and get an x-ray and some labs to look for infection. When I took her from Mom to move her, she began crying unconsolably. And it was a really terrible high-pitched cry, the kind of cry that we've all learned to recognize. When I got her to the treatment room, she sneezed 7 times in a row as I transferred her from the bassinet to the radiant warmer. And so that obviously raised some red flags for me. While we made plans to transfer her to the NICU, I went back into the room to talk with Mom and discuss our plan. While I was explaining the tests we were running and how her baby was doing, I asked her if she'd taken any medicines or other substances during her pregnancy that she hadn't told me about the first day I met her. Mom said, nope, she told me everything. However, as I was leaving the room, Mom called out, hey, Dr. Scott, can I talk to you for a minute alone? I had my residents and med students with me, and I asked them to leave. And Grandma was in the room, and I asked her to leave too, and then the mom said that it was okay for Grandma to stay. At that point, the mom began crying inconsolably. She said, I need to tell you that I did something really bad, but I don't want my baby to be sick, so I need to tell you what I did. She then went on to disclose that she had started using heroin about a year prior when she was dating a man who used as well. Upon discovering that she was pregnant, she said around 24 weeks, she disclosed this to her mom, who actually helped her detox at home without the care supervision of a medical provider. However, in the few months since she had detoxed, she had had several relapses, and she admitted to using Xanax and other pain pills that she had borrowed from a friend to help her through the heroin withdrawal. I thanked her for being so honest with me so that her baby could get the treatment that she needed. Mom began to sob, and I knew the question that was coming next. She said, I do think I'll be able to take my baby home with me. She said that she knew that she needed help, that she'd been so scared of having her baby removed that she hadn't reached out to her OB providers. The baby did get transferred to the NICU and was started on morphine that day to control her symptoms. Mom got the help she needed and is now receiving counseling and her own treatment. Her daughter got discharged home with a foster family, but with the hope of having the family reunited again very soon once Mom is sober and clean. So the reason why I shared this story with you out of the many, many stories of NAS I could share is because in the past, NAS was something that neonatologists alone cared for. However, this baby could have presented to any of us in any one of our hospitals, to any pediatrician or family medicine provider, any one of our nurses. What scared me so much about this case is that this baby was an hour away from leaving her hospital, and she likely would have gone home and gotten very ill at home without treatment. This was a really good example of how drug addiction can affect anybody. I really liked this mom. She was a nurturing, involved mom. She was doing awesome breastfeeding. If you'd asked me that morning, out of the 16 other babies I'd seen that day, she probably would have been the last one I would have expected, having been using heroin throughout most of her pregnancy. America now is in the middle of an opioid crisis. Whether it is abuse of heroin, synthetic opioids, or prescription drugs, the CDC reports that more adults now die from drug overdoses than motor vehicle accidents or gun violence. Drug overdose is the leading cause of accidental death in the U.S. Our opiate abuse epidemic knows no boundaries anymore. We all have to be vigilant and keep this diagnosis on our radar. While our country struggles to stop the rise of narcotic abuse in the U.S., we need to focus our attention on our country's youngest victims of the drug abuse epidemic. These are the tiny lives impacted by maternal opiate use during pregnancy, putting babies at risk for neonatal abstinence syndrome. NAS is defined as a constellation of clinical findings associated with drug withdrawal in a newborn. It's a multi-systemic process that involves the central nervous system, the autonomic nervous system, and the GI tract. While we focus most of our attention on NAS caused by opioid exposure in utero, babies can also develop NAS from chronic prenatal exposure to other CNS depressants such as benzos and alcohol. SSRIs also have been linked to a similar poor neonatal adaptation syndrome. Although other prenatal exposures can cause neonatal withdrawal, we're going to focus the rest of our presentation on NAS from opioids, which is by far the most common withdrawal we're treating in our nurseries and NICUs. What is crucial to keep in mind is that the vast majority of newborns exposed to opiates will be affected. In fact, studies show between 55 and 94% of babies exposed to opiates before birth will show some form of withdrawal. In our nurseries, we see NAS from a multitude of causes. Heroin or prescribed substances used illicitly are the most frequent culprits. However, we also see the babies of moms who are in recovery from opiate abuse but are dependent on maintenance opioids, such as methadone or buprenorphine, which is also known as Subutex. We have also recently seen an increase in moms self-medicating with these maintenance opioids or using street Suboxone that they're getting after it's been diverted from somebody it's been prescribed to. Another large population we see is moms who are prescribed short-acting opioids during their pregnancy. This problem was highlighted by a recent study in Pediatrics, which described the NAS population in Tennessee. In this study, 30% of Medicaid moms in Tennessee were prescribed opiates during their pregnancy by a physician, and 65% of their NAS cases were actually due to legally obtained opioids. The symptoms of neonatal abstinence syndrome are well described. They can include the insoluble high-pitched cry, poor sleep and feeding patterns, babies being really jittery, babies having diarrhea and vomiting, increased yawning and sneezing, that classic increased tone, tachypnea, and fever. Not all affected babies will have every symptom, but they likely will have a combination of several. Babies can go on having to have seizures, failure to thrive, and dehydration as well. And these are the more poor outcomes that we try to prevent with some of our treatments. Neonatal abstinence syndrome is not a new problem. In fact, the first case report of an infant with congenital morphinism was described in 1875. In 1892, a case series of 12 babies was reported in the literature, and actually 9 of those infants died. In 1903, doctors began trialing treatment with morphine in these newborns with success. When methadone and buprenorphine were introduced for treatment of opioid addiction, cases of NAS from these substances shortly followed. In 2002, we saw our first case report of NAS from OxyContin. And now here we are at the end of the graph in what is being termed an NAS epidemic in our country. This data is from a 2015 article published in the New England Journal of Medicine. It looked at 674,000 infants admitted to 299 NICUs from 2004 to 2013 and identified 10,000 infants during that period of time with NAS. Rates of NICU admission for NAS almost quadrupled during this time period, from 7 per 1,000 to 27 per 1,000. However, even with all the experience we now have treating these babies, our length of stay for this patient population is actually not improving. That same article showed that the length of stay for NAS increased from 13 to 19 days during the same time frame, from 2004 to 2013. When we look at national data, the CDC released state-by-state data from the last 2 decades this past August. They were able to look at 28 states with publicly available data and showed that the overall incidence of NAS increased 300% from 1999 to 2013. In 2013, the NAS incidence ranged from a low of 0.7 per 1,000 births in Hawaii up to 33.4 per 1,000 births in West Virginia. 3 states, West Virginia, Maine, and Vermont, had rates of over 30 per 1,000 births. The CDC estimates that about $1.5 billion was spent on NAS care in 2012, with 80% of these costs falling to Medicaid programs. Indiana was not included in the CDC analysis. We suspect that our rates of NAS in Indiana are comparable to other Midwestern states. After all, our state received national attention for the HIV outbreak in Scott County related to the opioid epidemic. The CDC ranked Indiana 9th in the country for the number of pain prescriptions written per 100 people in 2012, with more than 1 bottle of pills for every person in the state. However, we are not entirely sure what Indiana's actual incidence of NAS is. This problem was identified when pediatricians and other healthcare providers approached the Indiana government to help with resources for programs to prevent and treat NAS in Indiana. The Indiana Perinatal Quality Improvement Council Perinatal Substance Use Task Force is working diligently to standardize screening and reporting of NAS so that we can get a better handle on the numbers in our own state. There are pilot programs taking place in multiple hospitals in Indiana working on standardizing care for this population. Data from these pilot hospitals are just starting to come out, as highlighted by this IndyStar article from this summer citing high rates of opioid-addicted babies. The IPQUIC task force has given me permission to share this preliminary data out of our pilot hospitals. As you can see, in our sample in Indiana, 20% of babies who had their cord blood or their cord tissue tested for drug exposure in utero were positive for opioids. That is well above the rate in national samples. If you had told me 3 years ago that I would have been all over the state talking about NAS and even presenting this topic nationally, I would have laughed. In fact, I started off dreading talking and caring for these drug-addicted babies. I would literally get tachycardic when an opioid-exposed baby delivered. I felt like my relationship with the family was set up to be adversarial from the start. The family would often get defensive and upset. That would make me defensive and upset. But what I realized is that it was really just my own discomfort in dealing with this population and the fact that our hospital system really didn't have a good structure in place to do a good job for these families. And then about 3 years ago, I moved from my job, caring mainly for pediatric patients at Riley Hospital, to work in the newborn nursery at Methodist while training our medical students and residents. One of my questions when I moved over, because I dreaded it so much, was, well, how many NAS babies do you have exactly in the hospital? And the answer I got from the team was actually, we don't have that many, maybe like 1 or 2 a month. Well, I started in December 2013, and all that seemed to change quickly. We started caring for lots of opiate-exposed newborns, and our numbers have just climbed from there. One weekend, a couple months ago, we actually had 8 opiate-exposed full-term babies born within 3 days. Our service typically has at least 2 babies that we are monitoring a week. When I started at Methodist, I found that I wasn't alone in my discomfort caring for NAS babies. All of our staff seemed hesitant and unsure. However, we quickly realized that we couldn't avoid this, and so we decided to embrace this population in our maternity center and become really, really good at taking care of them. If you don't remember anything else from this talk, the most important tip I can give you is to make sure you get everybody on the same page. And this requires some work in some communities that's not set up this way already. OB providers need to be counseling moms on the risk of NAS in their babies from the get-go. Moms need to be aware, well before they deliver, that their baby will need prolonged monitoring and an extended stay in the hospital. It is absolutely not fair for these moms to find this out when they walk into the hospital to deliver. Ideally, whoever is counseling mom in the community needs to be reinforcing this message. Nursing teams, both on the inpatient and outpatient perspective, need to reinforce the same message as well. All pediatric providers need to practice according to the AAP recommendations for monitoring at-risk newborns, and the baby's primary physician after discharge has to be aware of the intrauterine exposure so that they can monitor the baby closely for any potential complications after discharge. The NICU team in the hospital or at another facility needs to be ready to accept any baby if the baby needs more intensive monitoring or medication. Hospitals need to have a consistent method for screening moms for drug use during their pregnancy. In September 2013, Cincinnati instituted universal toxicology screening for all moms. If the mom did not consent to testing, the baby was screened automatically. The focus on their screening was not to get legal services involved, but to make sure their mom had access to resources and to make sure they could adequately watch the baby for presentation of symptoms associated with NAS. Cincinnati reports that 20% of their babies exposed would have been missed with more traditional risk-based screening. While universal toxicology screening is done in other parts of the country as well, Cincinnati's program has been the most visible. Surrounding counties in Indiana have expressed some concern that some moms may cross the border from Ohio to Indiana to deliver in our state to potentially avoid that universal tox screen. The ACOG recommends universal verbal screening of all women using a validated tool, like the 4 Ps. If that screen is positive, urine screening is done on mom. Our practice is to do the verbal screening in addition to risk-based testing of all moms and babies who have had absent, late, or inadequate prenatal care or an admitted or documented history of drug abuse in the past. However, the Quick Perinatal Substance Use Committee is looking to standardize the screening process throughout the state to make sure we're all doing the same thing and to decrease the risk of moms going from hospital to hospital to avoid detection. There are 3 commonly utilized ways for testing for drug exposure in utero. Urine drug screens can be done on mom and baby. They are inexpensive and have a really fast turnaround time. The disadvantage is that we sometimes pick up drugs given in labor, and we often miss baby's first void, especially if they void immediately after birth or urinate around the bag. Meconium drug screens will test for exposure down to 20 weeks gestation. The disadvantage to meconium drug screens is that it can be kind of time-consuming to collect. You may need several stools to collect enough sample, and sometimes parents, purposely or not, will throw the diapers away. Umbilical cord screening is coming into favor more and more, either as a standalone test or in conjunction with urine screening. Umbilical cord screening gives results down to 20 weeks as well, just like meconium. The advantage of umbilical cord screening is that the sample can be collected immediately at birth on everybody. Babies with a concerning clinical history can have their cords sent off right away, but otherwise the cords can be kept for a week or more and sent off at a later time if the baby starts to develop symptoms. There's a fairly fast turnaround, usually about 1 day for negative results and 2 to 3 days for positive testing. They had been slightly more expensive in the past, although the cost is starting to come down, and if you're doing it as a standalone test, it may not be that much more expensive than doing the urine and the meconium together. When we're identifying couplets at risk for drug withdrawal, the earlier the better. This allows mom time to get into treatment for her opiate abuse, and it helps us get counseling and services in place for the family. It also allows the pediatric team to be prepared to monitor the baby appropriately. The focus of early detection, as I said before, should not be for punitive reasons, but to focus on involving appropriate services for mom and baby. We assess babies for symptoms of withdrawal using the modified Finnegan scoring system. There are other NAS scoring systems available, but the modified Finnegan is the one used most often in hospitals in the U.S. The Finnegan scoring system looks at 21 different items and assigns each a score. Baby is scored every 3 to 4 hours, ideally right after a feed. There can be concerns for inter-observer reliability, since some of the symptoms are more subjective. This concern can be addressed by consistent training of our nursing staff, using two-person scoring, or training Finnegan super users to help out as well. It's important to recognize the timing of withdrawal depends on the substance used. NAS from heroin presents the quickest due to the short half-life of the drug. Prescription short-acting opioids typically present between 36 and 72 hours, while our maintenance opioids typically start showing symptoms around 48 to 72 hours, but can be delayed or reach more severe symptoms around day 5 to 7 of life. Methadone-exposed infants also may have an intense initial phase, followed by a chronic relapsing course of irritability, poor sleep, and hyperphagia. Babies at risk for NAS need to be monitored in the hospital for a prolonged period of time to ensure that we are catching withdrawal before discharge. The recommendations for safe discharge are at 3 days for short-acting opioid and at 5 days for longer-acting maintenance opioids. All discharged babies need close outpatient follow-up and careful counseling to the parents about symptoms to watch for at home. Moms should be encouraged to breastfeed their babies if they are on maintenance medications. Moms abusing illicit substances, particularly in the 30 days to 90 days prior to birth, should be counseled against breastfeeding due to the risk of the substance affecting the newborn. This slide shows why breastfeeding is so beneficial to our newborns at risk for NAS. This study compared infants at risk for NAS that were exclusively breastfed with infants who were formula fed. In the first few days after birth, babies had lower Finnegan scores if they were breastfed. Infants were less likely to require morphine, and if they did, had a lower total morphine dose. Their length of stay was also decreased. In addition, it helps get mom involved in supportive care for her infant, helps with maternal bonding and baby bonding, and also these moms report less stress as well in the postpartum period. What I think is truly interesting and hopefully will be a direction we can all go in the future is that there's emerging evidence that these infants have much better outcomes if they are allowed to room in with their moms 24/7. In this study that was just published last summer, babies were transferred from the postpartum unit to the pediatric floor once their mother was discharged from the hospital. The family was encouraged to remain at the baby's bedside and maximize supportive care for the infant. The team scored the baby immediately after feeding while the baby was skin to skin with the parents to maximize baby's comfort. They also guided treatment based more on the overall clinical picture rather than just the Finnegan score. They put more emphasis on harmful signs and symptoms such as poor feeding, GI symptoms, weight loss, and inconsolability, and not so much emphasis on the symptoms that may not clinically matter as much, like sneezing, yawning, or mottling. The results that the hospital published were truly remarkable. They dramatically decreased the number of babies that they had to treat with morphine. If they were treated, they needed a lower cumulative dose. If they were treated, their length of stay was decreased. They had a decreased cost of the overall hospital stay, actually cut it in half. And they had no increase in adverse events or 30-day readmissions. So even though they were treating less babies, sending more babies home with their parents, they didn't see a whole bunch of babies coming back to the hospital getting sick. Before we meet families after delivery, hopefully they've already been informed by their OB or prenatal peds consult about the risks of NAS and what to expect. However, when we meet them again after birth, we want to reiterate very clear expectations. We have found it very helpful to have several staff members together for this conversation. For example, the pediatric provider, the bedside nurse, the lactation consultant, and the social worker. This helps family understand that the medical team is all on the same page and make sure everyone is following the same plan. When we have these conversations, we really want to ensure mom's privacy. I'm constantly surprised at how many women have not shared with their significant other or family that they are abusing opiates or opiate dependent, even if they're on methadone or buprenorphine. So we ask everyone other than mom to leave and then ask her who she wants in the room as their support person involved in the conversation. If she does want somebody back, we ask them to come back into the room so they can be involved as well. We always make sure we excuse guests who may be present during our daily visits as well if we don't recognize them or we haven't gotten consent from the parents already to discuss with them. Again, the earlier the better. You really want to make sure families understand the length of stay, that the baby will need continued monitoring, and a longer length of stay if they need treatment, when the Finnegan scores are going to be done, who's going to be doing them, and how the family will find out the score. We want to promote breastfeeding if that is a viable option for that family and mom has not been abusing illicit substances recently. We want to find out, and this will be different for every hospital you guys are at, but is rooming in an option for this mom? If so, kind of what are the rules of that and how do we set that up? And then we want to be very clear with parents about when medication would be considered or be started. With our families, we want to set really realistic expectations with them. After all, as we discussed on one of the first slides, we know that the vast majority, 55 to 94% of babies will withdraw. And it's really important that parents understand that. We do want to try to stress that just because their baby withdraws doesn't mean that they need medication. We want to really empower the family to engage in supportive care and to remain really hopeful that the baby is not going to need medication. But we want to make sure that they understand that if their baby's sick and needs help to feel better, we have to intervene with the baby medically. We make sure that they understand that our entire team's goal is for them to get home as soon as possible with a healthy baby. Hopefully in 5 to 7 days if they're on a long-acting medication, but if the baby needs treatment, then it'll be longer. But we want to make sure that baby is completely stable before we let them leave. We have found that giving parents ways to get involved can be tremendously helpful. Empowering them to take charge of some of the Finnegan scoring, especially the sleeping, yawning, and sneezing logs, can be really effective. Sometimes I've heard our team members worry that parents hide symptoms from us so that they can take their baby home sooner and prevent treatment with medication. And while this certainly happens, I can't deny that, I have found that equally often parents actually tend to elevate symptom severity because they are so worried about their baby being in pain. This seems to be a particular issue if the mom or dad has recently undergone withdrawal themselves from an opiate and they are very, very sensitive to how their baby's feeling. So I mentioned many times before, they're a good candidate to breastfeed. We work on this a lot. We work on really soothing skin to skin, putting the baby at the breast, and also often get moms started pumping soon so that we can help hasten her milk supply to transition and have some supplies in case the baby loses a lot of weight and needs a little bit of supplementation. These kiddos are at higher risk for having increased weight loss due to that increased metabolic demand that they have. We also tell parents that they are going to be the expert in finding what soothes their baby the best. We give them a whole bunch of tips and then let them figure out what works best for them and their baby. We do encourage the families to keep their room environment quiet with low stimulation. We try to have them keep guests to a minimum. The last thing a baby kind of on the edge of withdrawal needs is a loud uncle kind of bouncing them up and down and talking really loudly in the baby's face. I don't know if you guys have heard this before, but one thing that happens a lot where I work is sometimes I'll hear the nurses say, well, that baby had a really, really good score, but mom is holding her all the time. I know that if I could have gotten that baby alone for a little bit, she'd be scoring high enough to get treated or transferred to the NICU. My nurses now know not to say that because it's probably my biggest pet peeve in caring for NAS babies. The reason why it bothers me so much is we actually want these babies to do well. If mom is doing a great job at supportive care for her baby, she's able to do the skin-to-skin and soothe the baby, and the baby's comfortable, then that's great. If they get a score of 4 when the baby's skin-to-skin, fine. I'm super happy for that family. That's what we want. We really only want to be treating babies who can't be managed despite good supportive care techniques. At the same time, I understand our nurses' concerns. I know that they genuinely want to make sure the baby's safe to be discharged, and sometimes that discomfort or worry causes us to want to elevate the score or make sure that we are catching everything just to make sure that we're sending them home to be safe. We really want to keep an environment in our hospitals where these concerns can be addressed openly between the doctors, nurses, and the parents. What I frequently tell my residents and med students is if a parent is doing a great job at supportive care, I find it very, very unlikely they're going to go home and not do that at home. I said if the parent's been here every single day and is doing skin to skin and is rocking the baby and is soothing the baby, I don't think that they're going to go home and stick their baby in a closet and forget about him and let him scream all the time. So we really try to just really emphasize that, you know, let these parents do a good job. This is what we want. This is a good home environment for these kiddos if these parents are stable and sober at this point and can manage this. If our babies are withdrawing significantly despite our best supportive care, then that's when we started treatment with an opioid. Traditionally, treatment's been started with 3 consecutive scores of 8 or higher, or 2 consecutive scores of 12 or higher. However, there are other protocols out there that use different triggers to initiate treatment, and those are all being evaluated. There's no one treatment protocol that is the best one that we should all aspire to. If the baby can't be controlled after escalating the morphine dose, sometimes an adjunctive medication like phenobarbital or clonidine can be added on. If you work in a hospital that treats NAS babies, either in your NICU or nursery, the most important thing is having a protocol. It honestly doesn't matter what your protocol is, but there was a great study in 2014 that showed that just having a protocol alone, no matter what it entails, is enough to have a significant decrease in length of stay, which obviously has a lot of benefits for both the family and the hospital. You want to make sure everybody agrees on when to start treatment, when to wean doses, and that is very, very set in stone and there's not deviation from that. That is really what makes a difference in getting these kids out of here as early as possible. Whether you're discharging these babies home from your nursery after a 3 to 5 day observation period or sending them home from the NICU after they've been with you for weeks weaning off morphine, it's really important to know what kind of an environment the baby is going home to. Who's going to be in the home? Who's going to be mom support? These moms, especially if they have a history of opiate dependence themselves, which they do, really need a lot of support and help with themselves staying sober. Is mom going to be weaning off her maintenance medication soon? That's going to set her up for her own withdrawal symptoms and relapse, and that might not be the best environment for these little peanuts to go home with when they're already a little extra fussy. Does the family already have support services in place? Are they comfortable with their pediatric office? Do they have resources? As pediatric providers receive these babies in the community, they need to keep careful watch over growth and weight gain. These babies tend to be smaller over the first 2 years of life, but catch up in all areas except height, where they are 4 centimeters shorter than their age-matched peers. There is conflicting evidence in the literature as to whether there is an impact on these children's neurodevelopment, but keeping a close eye on their development with early first steps referrals are very key. There is evidence that these babies actually have more problems with visual acuity and strabismus, so watching them closely for vision problems is important. And like we've stressed, these families need to have a good outpatient support network with their PMD, social worker, and other resources like home health nurses or healthy families. Mom also should be encouraged to remain in treatment and counseling, as addiction is a chronic illness. Finally, some of our biggest barriers we face when treating the NAS population is our own bias. It's very normal to think, wow, mom's the one who got herself into this situation. If she hadn't been using drugs, this baby wouldn't be suffering. I'm going to admit I used to think this all the time, especially when I was first starting out in practice. However, once I spent a lot of time with these moms and got to know the families, I realized that for the most part, they are just people who made a small decision that sent them down a bad path. Most of them are trying to get their lives together and be good parents to their kids. However, every now and then these thoughts pop back into my mind. Maybe mom has been really confrontational. Maybe she hasn't sought out the help that she needs during her pregnancy and is abusing illicit substances right to the end. Maybe the baby's gotten really, really sick, and it really hurt me to see that. Whenever I sink back into my own bias, I think about this quote from Stephen Patrick, who's a neonatologist at Vanderbilt. He's done a lot of work with the NAS population. What he says is, it's time for us to reshape how we view addiction in the U.S. It is a medical decision or a medical condition, not a moral failing. While we work to deal with our own bias, we have to acknowledge that moms feel very guilty about their baby's illness. I have found this to be particularly true if they have had a bad experience with withdrawal themselves. They know how bad it feels, and they can't imagine their newborn feeling that way. In addition to blaming themselves, these moms feel blame from all around them, from their significant other, from their family members, from their friends. We want to be very, very careful that they don't feel like we blame them too. We're their doctors, and nurses, we should be their source of support. We try really hard to find something the family is doing well and praise them, whether they are breastfeeding, working diligently at doing good skin-to-skin, being really upfront about symptoms they are noting. Sometimes I tell my residents it's hard to find something that you feel like they're doing well. Sometimes it's just that they keep the room really dark, and maybe that's not, maybe that's because they want the room dark, but even going in and saying, wow, you're really listening to us, you're really not turning the lights on and being really loud around your baby, this is really helping your baby. Finding some way to praise them really helps kind of keep them engaged and helps them feel like they've got this, they can handle this. Finally, if the family gets angry and tries to take it out on you, don't take it personally. This was a very hard lesson for me to learn. I tended to take a lot of this home with me at the end of the day, which is probably why I didn't like it very much. Parents are scared for their baby, and sometimes that fear gets expressed in anger at the wrong people. I will say that when I first started working with this newborn population, parents got angry with me a lot, and a lot of that was often because I was the first person to mention to them that their baby was at risk for NAS and would have to have prolonged hospital course or potentially morphine. Once our hospital got better at making sure these moms got really good prenatal counseling and knew what to expect before they came in, a lot of those emotional moments or those initial breakdowns got taken out of the equation, and our relationship with the moms from the pediatric perspective really got a lot better. So I'm a newborn hospitalist. Most of the time I see families for 48 to 72 hours tops. My families with opioid-exposed babies are my long-term patient relationships. I call my 7-day-old babies who are still with me getting FIN scores my elderly newborns. You may be surprised that no matter what the outcome, some of the biggest and sincerest thanks that I've gotten have been from these NAS families. I wanted to share with you an email I got from one of my moms this past year. She said, "Dear Dr. Scott, I hope you don't mind, but I looked you up on the directory. You took care of my baby a few months ago, and we had a very tough week to say the least. I was just thinking of you and how your team made the experience so much better. I really was having a tough time, and you helped me more than you know. You and your team took the time to talk with me and ease my fears when I was completely out of my mind. You'll never know how much that meant to me. Just wanted to thank you and let you know that my baby is perfect. At 3 months old, he is 13.5 pounds and 24.5 inches, and he's wonderful. I've attached a picture for you. This is not him. That's my kid. Keep doing what you do so well. You're a blessing." So while this never, ever, ever would have been the path I imagined I would be on, I'm so grateful that I'm on it now with my amazing team at Methodist. I do not want to at all imply we do this perfectly. There are lots of things we still need to work on our own hospital system, including really stressing our rooming in and skin-to-skin scoring with our families. However, I would really encourage you guys to think about changes you can make in your own hospital or outpatient setting to improve the care of our opiate-exposed babies and families. This is a problem that's not going to get better anytime soon, so we might as well embrace it and really work hard to provide these families with the care that they deserve. I promise you that in the end, it will be worth it. I left a lot of time for questions at the end because I know a lot of people have questions about this and have stories to share too. So I'm going to let Julia kind of guide us on how we're going to go through questions.
Well, thank you, Dr. Scott, and those are awfully cute babies you have.
Thank you.
And good photography. Uh,
Thanks.
so let's have you send questions. There should be a way to, you can do that on your go-to screen. So here's a question, our first question, which is, will a copy of the presentation be sent after the webinar? And we always put the actual presentation itself, which has both the sound and pictures, on YouTube. So that's a standard thing we do. I do think that I have been asked before, we've been asked before about having the slides themselves. And so we'll ask Dr. Scott if she can supply those, and if she minds having us send those out. To all of you who are on this now, and we have a report that shows us who's actually connected. So
they'll be on the website.
They'll be on the website. That's what Marquette tells me. So other questions, please. Thank you, Dr. Scott. That's the beginning. Do you ever monitor babies at risk for NAS more than every 3 hours? I would never want to wake a baby to score, correct? Also, Can we watch the webinar later? Yes, well, that we just answered that one. So,
yes. So typically what we do is we score them after they feed. So if they are feeding, and this gets a little bit more tricky with our breastfed babies because sometimes they're cluster feeding or feeding, Q2 or whatever. And so I think it's fine as long as you're staying around the 3 to 4 hour ballpark. You are absolutely right. We never wake our babies up to score them unless they have a score of 8 or higher. If they score 8, then they're supposed to get scored Q2 until their scores fall below 8. So that's probably the only time that we ever would potentially wake them up to score them. Usually when they're already getting an 8, they're not sleeping 3 hours at that point anyway. So I think that's probably the only exception. We do have kiddos who we have to wake up to feed if their weight is kind of gone down significantly. So if they're having like 11 to 12% weight loss, I'll have the parents wake them up every 3 hours. So that's probably the only other exception to they're not letting them sleep as long as they want to rule. But if they're sleeping that great, then you probably don't really have a problem.
Okay, great. The next question is, are there any local support groups for these families that you are aware of?
So the only one that, a lot of moms get information from their methadone clinics, which I think are getting a little bit better in terms of giving out accurate information. When I first started having these kiddos, it seemed like that was probably the biggest source of fake news, to use a media term right now, for our families. I know Volunteers of America has a lot of support for these moms and even has some rooms for them to stay in. And so that's the only one I'm aware of off the top of my head that you could look into. I can ask my social workers too, and I can get back to you guys and send that out in an email.
Here's another question. How are you scoring cluster breastfeeds?
So that is a good example of kind of taking the score in context. So if we have a baby who is truly cluster feeding, like, in the middle of the night, like they all do, and that baby is scoring just because they're not sleeping like 3 hours between feeds, because as you guys know probably on the Finnegan scores, if you sleep like less than 3 hours, it's like 1 point, less than 2 hours, it's 2 points, and I think less than 1 hour is 3 points. I kind of take that into context when I'm looking at a score. So if a kid's scoring like an 8 or a 9, but 3 of the points are because I think they're cluster feeding, and everything else is kind of a soft score like modeling or, not feeding, being a little bit hypertonic, that might be a baby that I kind of hold on to a little bit longer and don't necessarily start them on morphine. So, yeah, I think you just kind of have to, take it in the context of what it is. And if it seems like it's normal breastfeeding behavior for a 2-day-old or 3-day-old, then I kind of ignore it a little bit, to be honest with you. that can be different. So sometimes our lactation consultants will go in and see the baby, and I rely on them a lot. And if they say, gosh, this kid is like at the breast, cluster feeding, but is truly like frantic and is like, moving, I mean, you guys have seen these kids moving their head from side to side, like not able to latch on because they're so aggravated and vigorous. And we think that's more from withdrawal, then I would take it more seriously. But if it just seems like kind of normal stuff that we'd see in any other room, I don't make it a whole bunch of it.
Okay. Here's another question. Dr. Scott, there has been a discussion between multiple hospitals regarding scoring tremors. A few hospitals stated they are not including the score for disturbed and undisturbed. I think I'm undisturbed, sorry. No, which one is it? Is it undisturbed, disturbed, and undisturbed?
Yes, that's right.
I read it wrong.
You got it.
Adding the two numbers into the total, for example. They're just scoring the infant the highest score between the four scores. I think.
So I've been involved in these email conversations, so I know exactly what you're talking about. Yes, so there is some discrepancy on the modified Finnegan scoring system where there are different ways to score tremors. So sometimes you add in the undisturbed and the disturbed tremors together, or sometimes you just pick the highest of the four. We have been picking the highest of the four, but we started questioning whether we were doing the right thing as well here at Methodist. So I sent this question out to our national listserv to try to get more information, and what I got back was a whole bunch of a mixed bag, basically. Some people did include the both together, and some people just picked the highest of the four. I did get actually, interestingly enough, a response back from the person who wrote that paper that I showed you guys about the family-centered NAS care, who basically was like, does it matter? Like, if all they're having is tremors, is it that big of a deal? Should you really be worrying about that 2-point discrepancy if the kid, or should you be going more on like poor weight gain and poor sleeping and that kind of stuff? So I hear you. I honestly don't know what the right answer is, and I've been trying to investigate that myself. I personally am hesitant to go to adding the two together because that would, for our hospital, potentially be having us send more babies to the NICU and having more babies get treated because we are typically right now just taking the highest of the four. And we've had really good success at doing things the way we've been doing it without any bad outcomes. And so I don't want to even potentially set us up where we're treating more babies. So I don't think that was a helpful answer to you, but you are absolutely right. There is some discrepancy, and I don't know why all the scores are called the modified Finnegan, and they're not all exactly the same. I actually took it to the ISDH as well, and they didn't give me a really great answer either.
So maybe that's one of the conversations that will continue as we move.
I think so. Yeah.
Especially as the standards are coming out of, or the development of those standards are coming out of IPQUIC and the pilot programs, trying to figure out what the best way to do that. So, okay. So here's the next question. I'm a community health nurse with Nurse Family Partnership. We have a first-time mom who, I guess we have first-time moms who are addicted to various drugs. What should we do to prepare moms prior to going into the hospital to deliver? And what should we assess for related, the babies who have been discharged from the hospital, and we know mom used drugs during pregnancy? Sure.
So I think that the nice thing about you having I love Nurse Family Partnership, so whoever that is, great job. I'm so glad you work for them. I think that the benefit you have with Nurse Family Partnership is having the first-time moms, because the way that things are set up right now in Indiana is that it's very non-punitive for moms to seek out help and get help. So if a mom tests positive for a drug of abuse and it's her first pregnancy, then there's, as long as she kind of gets clean and gets on the straight and narrow path, then there's really not going to be a whole lot of CPS retribution or CPS involvement, I guess. Not retribution is the wrong word, but CPS involvement at the end of that. It's a little bit different if moms are abusing drugs and we find out about it during their pregnancy and they have other kids in their home. So it's a little bit easier when you can really empower them to kind of get treatment and get help early, so that, you know, we can kind of show evidence that when they are coming in to deliver and their baby's been born, that they are really engaged in staying sober and not using any illicit substances. I think that, you know, preparing them to come into the hospital, making sure that they are really upfront and honest with everybody, because that goes a long way with us. In terms of making sure that we are able to monitor the baby appropriately, looking for any kind of other side effects that could be happening from drug abuse, whether it's, you know, opiates or whether it's cocaine or THC and that kind of stuff. And then from your standpoint, when the kiddo leaves the hospital, I think it's important just to keep a really close eye on developmental symptoms, keeping a close eye on mom to make sure she's not relapsing and she has enough support, but also kind of keeping an eye on the baby and just make sure that developmentally they seem to be doing okay. And if not, you know, and if you see something that you're concerned about, you know, making sure that the mom raises that concern with the pediatric provider and gets first steps involved.
Okay. Thank you. And then someone on the call is just telling us, it's as an FYI for the discussion about support groups, that there's a centering pregnancy program for moms on Subutex who receive meds from Midtown Mental Health, the 3171 clinic. So that's, if you've got an Indy connection, then that's a good. That could be a good resource.
That's awesome.
Okay, so next question. Do you delay treatment sometimes if there is polydrug exposure like tobacco or SSRIs? And because perhaps that is a temporary problem in the first 24 to 48 hours?
That is an excellent question, because we do know that the babies whose moms either smoked or were on SSRIs or benzos or something like that are actually at higher risk for having clinically significant NAS. And so it's not so much that we delay treatment, although I would say that we typically do expect, like, our babies whose moms smoke to have an increase in their NAS symptoms around day 1, and then they usually kind of fall back down again. So usually they can go up to like 5, 6, 7 the first day, and then they kind of fall back down to the 2, 3 range, and then they may go up again in a couple days. So I don't know that I have ever practiced where we don't treat them if they're truly having scores that need treatment, just because the literature shows that they actually are more likely to have a clinically significant withdrawal. My practice sees a lot more of the methadone Subutex moms, and so those babies' withdrawal is typically delayed a little bit farther, so it's a little bit easier to tease out what's the tobacco and what's the opiate, whereas I could see if you were in if you were dealing with a patient population where it was more heroin or more like Norcos or something like that, it might be a little bit harder to tease that out. So I have not done that personally.
Here's a question about social worker training, which you may or may not know the answer to, but we will have a social worker on in our 3rd installment of the NAS webinar series next week. So if you don't know it, we might be able to get it from her.
Okay.
Are there any special educational programs from the state or hospitals like Methodist for social workers who work with these families to be certified or at least more aware so they are giving the most supportive care? I have seen social workers not very educated on this topic, and an example is saying moms shouldn't breastfeed.
Yes. I am honestly not aware. I will say that I have the world's best social workers here. I'm sorry if you work somewhere else and you think you do. I do here. But I know they have done a lot of training. I don't know where they've gotten it done. So hopefully the person who's on the phone next week will be able to tell you that. But I do think, I agree with you. It's very, very important for them to be fully informed from everything from the, social CBS perspective up through the medical perspective, so they do understand which moms can breastfeed, which moms can't, and can help us kind of reinforce and support that with moms.
Okay, we'll make sure and ask Sabrina
Yeah, that's a great question.
quickly about that next week. Next question, can you speak a little more about umbilical cord analysis? Has it been a more consistent method of testing versus urine/meconium? And are you utilizing a national testing center to run these, or are they doing it in-house for you?
Mm-hmm. So it is more consistent for sure than umbilical and meconium drug testing. And I think the nice thing about it is that you can, if you happen to miss it, you can go back and grab it a little bit later. Sometimes I even had this happen to me, this past week. We found out after the baby had been born that mom had a concerning drug history that wasn't clear from her prenatal records. And so by the time we were trying to go back and collect stuff, we did not have time to get definitely the urine, and we were kind of at the later end for meconium. We actually haven't instituted umbilical cord testing yet at Methodist. We're in the process of getting that instituted. It does go to a national place, and the pilot hospitals who are doing the IPCLIC pilots, I think there's a specific testing site that they want everyone to use. So that's actually what's holding us up getting started, is we're in the process of making sure we can send our samples there. But I'm not aware of, and somebody may correct me, but I'm not aware of anybody here in Indiana who can run it on site at this point at our own hospital.
We might need to, so what we can do is go through some of these questions and see if there is somewhere that we can,
yeah, absolutely.
The folks in the NAS committee.
Yeah, for sure. They'll be able to answer that.
Yeah. So here's the next question. I often have parents ask about long-term development. Is there any long-term research about ADHD, learning disabilities, something like that?
Yeah, so there's actually a lot of research out there, but it's not the initial stuff that came out back in like the early 2002, 2005 range did not show any delays in behavior and cognitive development that could not be explained by what they call confounding factors. So basically, was it really the opiate exposure, or was it more the home environment and mom's own education level and that kind of stuff? There was a study that came out actually just last week that looked at a cohort study of babies in, I think, New Zealand or Australia, and that did show that as they actually got into 5th, 6th, 7th, 8th, 9th grade, their cognitive scores on testing declined. It declined actually quite dramatically over that period of time. I think that the hard thing at this point is that we have a lot of kiddos who are getting into the high school age now that were exposed when they were younger, but the huge cohorts of these kiddos that we're seeing now really haven't pushed through the school age yet. And I imagine there's going to be a lot more information out there because it just starts, it seems like every couple months now there's like a new article that kind of trickles in with a smaller sample. So I think we're going to have a lot more information on that as we kind of go a little bit further on over the next couple of years. But right now what I tell parents when I'm counseling them is there are some studies out there that show that the kiddos can have more problems with learning and test scores as they get older, and that's why it's super important for their pediatric provider to watch them really closely and to make sure that if we can intervene with something early that we're getting them those services.
So this is going to be our last question, and I'm sorry, there's a couple more that I'll send to you, Dr.
Sure.
Scott, and then that way we can maybe get some answers for these folks. But here's the last one. You mentioned that moms could have increased risk with SSRIs and benzos. I heard that babies can be diagnosed with very heavy smoking with no drugs. And have you seen that? Also, can a baby be diagnosed with NAS with mom just using SSRI without drugs?
Yes. So I have not seen a mom who smoked so much that the baby got diagnosed with NAS. There was a case report of a baby it was actually in pediatrics just this last month of a baby who presented just like they had NAS, and mom was on like massive amounts of caffeine every day, like way more caffeine than most people drink. Like, I mean, like probably like 8 or 9 cups of coffee a day, but the baby presented like they had NAS, which was kind of interesting. But I have not personally seen it with tobacco where they've gotten sick enough that we're like considering, you know, do they need medication? I have seen a couple of kids with benzos who do have NAS without having any opiate exposure, and it typically are the really, really heavy benzo-using moms. Also saw a baby who had what looked like NAS from alcohol exposure during pregnancy. The mom drank quite a bit her whole pregnancy, and the baby ended up having symptoms that were NAS symptoms pretty quickly after birth as well.
All right. Well, this has been fabulous, and as I know, as you know, we think you are fabulous, and we're so grateful for you to share your time and expertise.
Oh, you guys are funny.
So we'll send you.
Absolutely, thank you.
We'll send you these questions, and we want to thank everybody, and hope you can tune in next week.
Yes.
So thanks.